It's a pleasure to be with you. The title of this talk is Communications Model. There are no disclosures for this presentation. Objectives include understand culture shock and how it relates to public health messaging, understand the difference between messaging and transfer of meaning, discuss the basic concepts of a communications model, understand the importance of being respondent-oriented, discuss the role of contextualization in messaging, review attributes of successful behavior change programs, and understand how Maslow's pyramid relates to community message receptivity. A major question for us to consider is, does cultural communications apply to much of what we do in our situation, particularly in public health? We can see how this might apply to people with markedly different racial or ethnic backgrounds, but what about in our normal everyday situation? Let's ask a few cross-cultural questions. Do we ever use a different language than the person on the streets? In public health, we commonly use terms and words unknown to the average person. Do we have a different meaning in our heads regarding health issues than the person on the streets? Well, absolutely. Otherwise, we wouldn't need to use health messages at all. They'd already know what to do. Do we ever get frustrated when people don't change their risky behaviors after having received our well-crafted messages? If yes, you're suffering from a condition called culture shock, not understanding how people could be so ignorant or stubborn to continue high-risk behaviors despite knowing what to do. You just told them, and they didn't change. We've all been there, and most of us are still there. Did we ever consider that the problem could be a cross-cultural communications issue? The purpose of health communications is to effectively transfer messages that results in an appropriate meaning in the recipients of that message to ultimately change risky behaviors. Health professionals are often guilty of transferring well-selected words, not necessarily meaning. Transferring words is often not enough to convince people to change high-risk behaviors. It's all about meaning. True communication is therefore not actually the transfer of just messages or words, but meaning that will positively impact the behaviors of those we're trying to reach, the respondents. The definition of meaning is the input of our senses overlaid with increasing levels of abstraction. I have a problem understanding that, so I drew a diagram that represents what I think that means. All of our experiences, resulting from a myriad of various sensory inputs, are piled somewhere in the gray matter of our brain. They aren't necessarily arranged in discrete chapters, paragraphs, or sentences, but likely linked as related bits of information. Some of that information is good and some bad. Whether good or bad, it's the pile of information we have to work with. Whenever confronted with a situation or a received message that requires a meaning, we go to that massed pile of bits of information and create our personal meaning, a unique creative process for each individual, resulting in a unique meaning for each person, even when presented with the same message or situation. The main point, the meaning that ultimately impacts the behavior of respondents or recipients of a message, occurs in the respondent or recipient, not the source of the message. Health professionals often spend significant time creating elaborate messages that accurately represent our meanings, fashioned from minds representing the health profession culture. Yet we become frustrated when the meanings of respondents are different and result in little or no change in behaviors. The problem may not be in the words or message transferred, but in how the respondent crafted a meaning in response to that message. How do we determine if an appropriate meaning has been crafted? Feedback is a valuable early sign, followed by the ultimate outcome, the impact on a risky behavior. Let's consider a communications model developed by Claude Shannon and Warren Weaver. This diagram lists 8 parts to consider when communicating a message from a source to a respondent or recipient. Once again, the main purpose of health communications is to transfer messages that will create a meaning in the respondent, ultimately resulting in a change of high-risk behaviors. The source is a person or organization that possesses a health meaning. That source wants to transfer that meaning to a recipient or respondent. The source chooses a message medium, including things like conferences, meetings, newspapers, radio, television, billboards, social media, etc. The message is then encoded by the source into the message media of choice. Recorded PCA, crafted a post for social media, written an article for the paper, etc. The intent, the message will somehow result in the creation of an appropriate meaning in the respondent that ultimately changes risky behaviors. The message is then delivered through the chosen media. A speaker, especially an external source to a target community, must win a hearing by demonstrating that they are people of integrity, credibility, and goodwill. How do we win a hearing in a community? One of the best ways is to utilize a respected person from the community or culture as the messenger. We recognize these respected people by many names, including champions and opinion leaders. They already have community respect. They live in the target community and are part of the culture. Using a community opinion leader as a message source saves valuable time, enhances message credibility, and provides an excellent venue to culturally contextualize a message. Another way of winning respect is by spending time, sometimes months to years, in a community to develop relationships. This method of gaining respect is also known as enculturation. An important point is that the actions of any messenger, opinion leader, or other enculturated source must practice what is preached. For example, it's difficult for a physician who smokes to influence others to quit. This diagram illustrates the importance of using community informal respected leaders as message sources. In the best situation, for example, communication from one identical twin to the other, same family, same culture, same language, same everything, there is maximally an 80% transfer of meaning from the source twin to the respondent twin. Add any cultural difference between the source and respondent, language, generation gap, different racial background, etc., the transfer of effective meaning from the source to respondent decreases dramatically. The closer the message source is culturally, racially, socially, generationally, etc., to the respondent, the greater the chance of effectively transferring meaning. The word communication comes from the Latin word communis, meaning commonness. The more the source has in common with the respondent, the more efficient the transfer of meaning. Informal, respected leaders, opinion leaders, and champions within the community possess that commonness and are excellent sources of messaging to their communities. Other cultural factors that relate to the source or messenger and their impact in a target community or culture include age. Some cultures respect people over 60 years old, while others may not even respect those over 40. The United States tends to lean toward the latter. When I worked in Zaire, now the Democratic Republic of the Congo, I had a beard that was graying, though the rest of my hair was still dark. One day I shaved off my beard. My Zairean guard was shocked and exclaimed, "Doctor, you have lost your respect. You shaved it off." Gender. In some cultures, respected women can speak only of women's matters, and therefore may not be an appropriate message source for men. Other cultural factors to consider include family background, achievements, education, and military service. For example, for decades, military service was highly respected for Native American leaders of many tribes. That may no longer be the case. Religious affiliation may also be important for certain messages. These, along with other cultural factors, need to be considered in the selection of an appropriate message source to a target culture. Studying and understanding a target culture is essential in all aspects of messaging, including the selection of a messenger. Another important cross-cultural point to remember is that cultures are dynamic, not static. All cultures are constantly transitioning and adapting to the environment around them. Public health and other health professionals must understand the current cultural beliefs, values, and institutions that drive risky behaviors in target communities, and must also adapt to adequately meet their needs. The respondent then receives the message, decodes it, and creates a personal meaning. Remember, respondents have accumulated a pile of bits of information on numerous topics from multiple sensory inputs throughout their lives. Some of those bits of information are accurate and some not. The respondent may possess only small amounts of information related to the topic presented by the source. In that case, the respondent fills in the gaps as possible to create a personal meaning. Can we do anything in advance to determine how the respondent will decipher the message and create meaning? Studying the respondent culture may help and will often require spending significant time in a target community. Discussing the topic with key respected people in the community, opinion leaders, who represent the beliefs, values, and attitudes of the community may give insights. Focus group work could also help. After the message is delivered, look for early feedback and be willing to adjust the message if necessary. Message sources should keep 7 respondent activities in mind, including interpreting. Everything said and done is considered in interpreting the message. Constructing meanings. The respondent creates meaning from messages, reaching into their pile of information bits to form a meaning. Respondents grant or withhold permission for the communicator to enter their communication space. For example, as a pediatrician, it becomes apparent when an adolescent closes the doors to communication on certain topics, though they're still physically present in the office. Respondents evaluate every aspect of a communication, verbal and nonverbal messages, including body language. Respondents want to maintain equilibrium. Generally, humans like stability, just like stock markets cringe with uncertainty and inconsistency. There may be a price to pay in accepting change, like relationships, etc. Expect resistance when introducing a message suggesting change to a community. Respondents always provide feedback in various forms, including verbal and nonverbal. It's important for message sources to detect that feedback and adjust messages as necessary. Respondents are the decision makers, ultimately deciding what to do with the message. In other words, the respondent holds all the cards. Public health needs to be respondent-oriented, finding the right message source, content, and media to create a meaning in the respondent to change risky behaviors. True community engagement recognizes the importance of empowering the community to own their own problems and solutions. They are the decision makers. Feedback takes several forms, verbal and nonverbal. Looking for and responding appropriately to feedback is a part of active listening. A good communicator listens to all respondent feedback, verbal, including various written forms, and nonverbal, and adjusts a message as necessary to be more effective in transmitting a meaning. Freud said, "No mortal can keep a secret. If his lips are silent, he chatters with his fingertips. Betrayal oozes out of him at every pore." This emphasizes that 45 to 65% of all human communication takes place in the nonverbal realm. The whole communication environment takes place in noise. Noise is anything that inhibits the appropriate transfer of messages. Noise can impact all parts of the communications model. An obvious example of noise would be during a lecture or talk, having loud street sounds, or when room temperature is excessively hot, or if the lecturer has idiosyncratic behaviors that distract participants from listening. Other sources of noise can include conflicting messages from opponents of health messages, like tobacco companies, to create confusion. And politics can also be a source of noise when other agendas influence health policy versus science. Another influence is context. All communication takes place in a context. This relates to the timing and situation surrounding the communication. This graph is adapted from Dr. Peter Sandman's Responding to Community Outrage. The horizontal line represents the actual risk to the public or the hazard ranging from low to high. The vertical scale is the level of public concern ranging from none to outrage. The blue circle represents situations associated with no concern and low hazard or risk. This is the area of no problems requiring no response. The red circle represents situations with high concern to the point of public outrage, but with low hazard or public risk. Good examples of this would be SARS, severe acute respiratory syndrome, caused by a coronavirus first noticed in Asia in 2003. The anthrax attacks in 2001 post 9/11 is another example. The risk to the general public with both SARS and anthrax was very low, but the concern level was extremely high and even considered outrage. The public demanded that something be done. There is a component of the irrational in outrage. Outrage situations require outrage management skills that are well outlined in Dr. Sandman's book. Statistics are not the answer in an outrage situation when emotions run high. Outrage management requires a different set of skills, a more human, feeling, and understanding approach. This is difficult sometimes for scientists. We like our data and charts. When scientists respond to outrage with data, they come across as on-feeling and cold. The maroon circle is the area of true crisis, with both high concern and hazard. These situations require classic crisis management skills. The green circle is the area of public apathy, where there is high hazard but low concern. Chronic diseases and their risk factors often fall into public apathy. In this area, something is needed to increase the concern factor, not to outrage, but at least to a moderate level, the sweet spot where the public is interested in doing something. Context may help to move the public to the sweet spot. The definition of contextualization is making concepts or ideals relevant in a given situation. Situations often arise that capture the attention and interest of the public. Scientists, like public health professionals, don't generate the situation that elevates the public's concern to the sweet spot, but they can be opportunists, capitalizing on the situation to appropriately message. The North Dakota Department of Health was concerned about West Nile virus causing human disease in the state in the summer of 2003. There were several animal cases reported in 2002. During the early spring, the department produced several public service announcements to encourage mosquito bite prevention. There was little interest by the press or the public. It seemed the whole state was apathetic to the risks of West Nile virus. In August, several human cases, some deaths, and severe complications were reported. This situation elevated the concern of the state into the sweet spot. At that time, everything the department put out on West Nile infection was of interest, a prime time to message. A phone hotline was needed to answer the volume of calls. Public health needs to be more opportunistic, choosing timely messaging to capitalize on times when our public is in the sweet spot. This is sometimes a challenge for scientists who want to carefully schedule messages. When former U.S. President Bill Clinton had his CABG procedure, coronary artery bypass graft, a small window of time to message on cardiovascular disease was provided to public health. The interest of the public and press were in the sweet spot for several days. Unfortunately, public health did not capitalize on that contextualized situation. A message at other times will likely not be as effective. Let's talk about cross-cultural communications and the concept of cultural distance. There are 7 dimensions of cross-cultural communications. The more one culture, culture X, differs from another, culture Y, in these 7 dimensions defines the cultural distance between them. Those 7 dimensions include worldview or deep beliefs that informs the way a culture perceives the world, cognitive processes or ways of thinking, linguistic forms or ways of expressing ideas, behavioral patterns or ways of acting, social structures or ways of interacting, media influence or ways of channeling messages, and motivational resources or ways of deciding. So utilizing an informal leader, opinion leader, or champion as a message source is important, yet that messenger must also believe in the message. Eugene Nida identified 4 levels of identification with a message, including 1. Heard the message but no interest in changing a behavior. 2. Heard the message and will make a temporary but not permanent change in personal behavior. 3. Heard the message and will make a permanent change in personal behavior, but will not be a messenger to others. 4. Heard the message and will make a permanent change in personal behavior and will be a messenger to others. Informal community leaders must be at the 4th level of identification with a message, or they will not be a messenger to their community. So how can community engagement specialists move community informal leaders to the fourth level of identification with a message? Community engagement is facilitation of a community to own their problems and solutions. Community engagement is facilitation of a process of problem solving, not a project. If a community develops a viable, successful process to solve their perceived needs, their problems, they will continue to use that process to solve more problems. People will invest their energy and time in issues they perceive are important. Informal leaders will be messengers to solve problems they perceive are important for them and their communities. For these problems, their perceived needs, they will be at the fourth level of identification with the message. Starting at the perceived needs of a community is a major community engagement tactic to ensure that community informal leaders, opinion leaders, champions, will be at that fourth level of identification with a message. What are key attributes to change risky behaviors? This slide is information from the CDC Morbidity and Mortality Weekly Report, MMWR, from 2001, and discusses attributes of successful programs to change high-risk HIV behaviors in Africa, and includes high-level leadership support, use of best or promising practices, adequate resources, and community engagement, facilitating communities to own their problems and solutions. This is a diagram of Abraham Maslow's hierarchy of needs. The lower four levels are described as deficiency needs, where the top level is termed growth needs or being needs. While our deficiency needs must be met, our being needs are continually shaping our behaviors. The basic concept is that the higher needs only come into focus once all the needs that are lower are mainly or entirely satisfied. Physiological needs include such things as food, water, air, shelter, bodily comfort, and exercise, etc. The next level is safety and security. This is followed by the need for love and belonging and includes the social aspects of relationships, friendship, sexual relationships, acceptance, belonging, and to feel needed. The fourth level is that of esteem, or the need for respect, including self-respect and recognition by others. Deficiency needs must be mainly or entirely satisfied before growth, self-actualization, or self-transcendence can be pursued. The area of growth, self-actualization, and self-transcendence relates to making the most of one's unique abilities, search for meaning, and the pursuit of spiritual needs. This top of the pyramid is where effective community engagement occurs. This slide lists the attributes Maslow uses to describe self-actualizing people, groups of people or communities at the apex area of the pyramid. These include: they embrace the facts and realities of the world, including themselves, rather than denying or avoiding them. They are spontaneous in their ideas and actions. They're creative. They're interested in solving problems. This often includes the problems of others. They feel a closeness to other people and generally appreciate life. They have a system of morality that is fully internalized and independent of external authority. They judge others without prejudice in a way that can be termed objective. They're interested in planning for the future. Back to the pyramid. Primary prevention messages relate to future benefits. The area of self-actualization or effective community engagement on Maslow's pyramid. People struggling to meet their basic deficiency needs at the lower part of the pyramid are often not thinking much about the future. They're trying to survive in the present. Preventive messages that relate to the future may not be very effective in these situations until those deficiency needs are addressed. The needs listed on Maslow's pyramid are also defined as the determinants of health. Many of them relate to the deficiency needs listed in the 4 lower strata. Message receptivity may first require programs to adequately address the deficiency needs of a community, the necessary preparatory work for facilitating community engagement, where communities are ready to grow toward a brighter future. In summary, focus on respondent factors associated with their creation of meaning. Messaging when the public is in the sweet spot will improve receptivity, and message receptivity is enhanced when basic social determinants are adequately addressed.